My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
Yeah.
So what is the talk about the Norris? Is this like a 375 or a 35? What's the size on the
It's
Norris?
a 375. It's a 375 with a narrow apex. To me, it's a nicely tapered apex, and the rest of it is threaded to the crest. Same exact thread the whole way. It's not aggressively threaded, and it has that added benefit of the bald surface, the non-threaded portion mid shaft.
Mm-hmm.
Yeah. Do you think that would have any indication for use with transsinus as well?
Yeah,
I mean, it's kind of a similar concept.
Yeah, definitely. It's yeah. I mean, it's really, you don't need that non-threaded surface in the transsinus, but you don't need threads in the transsinus portion either. So
Sure.
it certainly can be.
Okay. Yeah. Fair. So one thing I don't think we've put a lot of attention to is pterygoid implants as well, right? So of course we've talked about the full gamut of of remote anchorage and things. So I'm curious, what kind of tips might you have for applying pterygoids in someone's practice? What kind of implant designs are you looking for there?
Yeah.
And are you a drill guy, osteotome guy, a little bit of both?
Great
Is it just
question.
Day of the week.
It's really funny because I did the same thing, by the way. I flew around the country watching people do this too, because there was really no defined techniques around and no real defined anatomical landmarks to use. And so it's funny that I'm not going to call myself one of the mentors here, but the few of us that started teaching this a while back, each one of us has kind of adopted points of the others, and each one has distilled their own techniques. So I generally use, I'll start with an osteotome. I really use every landmark that I can. I use the hamulus. Hamulus is the medialmost point of the inferiormost point of the medial pterygoid plate. That's going to be my end point. Typically, I'll just imagine a point 20 millimeters above that is going to be my aiming point for this. And depending on how much bone there is under the sinus, I'll start as far forward as I can underneath the sinus or in the posterior maxilla. So typically, let's say a centimeter in front of the hamular notch, which, by the way, you really do need to reduce the tuberosity to make sure you're not losing all that wasted bone there, wasted length of an implant. But once you do that, you can even feel it. The other trick that I've been doing most recently is I'll take the 2 millimeter sharp osteotome and dissect, with a periosteal, dissect the posterior to the hamular notch, and a little bit further posteriorly to see the fibers of the musculature. But then I'll take the pointy osteotome and put it between those two plates in the muscle, just a few millimeters, and use medial and lateral movement to actually, I'm hitting the medial plate, I'm hitting the lateral plate, and it really directs me to that medial plate. So that gives me a little bit more, every possible clue that I can get out of this patient, I'm going to use to get me the right direction. We have a very healthy respect for the pterygoid region, all the bleeding things that are back there. So medial is the way to go. And I'll use that sharp osteotome first just to get through the maxilla, hit the pyramidal process of the palatine bone, stop right there, and then go to the same burrs that I'll use for the transnasal, the sharp 2 millimeter long pilot, and then followed by that implant specific drill, and that's really it. But I use that, by the way, in the Zygoma handpiece, the straight handpiece that I don't use for zygomas. It's hard to use that for posterior zygoma, by the way, but it should be called the pterygoid. Should be called the pterygoid handpiece, because you're standing behind the patient, whatever you're doing, the same direction as the osteotome goes, the handpiece goes. And I use that handpiece with both of those drills, the pilot drill and the implant specific drill, almost as an osteotome. I'm sounding as I go, bone, 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 bone. And then I'll go to I definitely use the Rosensmeiler driver.
Mm.
I think that's a clutch. I was almost, I like saying I make fun of myself, but I was almost self-defecating, not just self-deprecating. When you lose an implant there, you'll lose more than an implant. You know what I
It's
mean?
the
Yeah.
worst. Yeah.
So it's a very scary moment. So that Rosensmeiler driver is just lock the implant in place. There's one for the internal hex connection. There's one for the neodent connection, which is SIN. I mean, you don't need to go without it, and it's just a way to stay safe. And that's it. I mean, it's from an implant choice. I like something more aggressively threaded, and generally I will leave the flat hex or the dot, depending on what implant company I'm using, facing forward, so that ever so slightly, a 17-degree, typically 17-degree or a 30-degree multi-unit will come ever so slightly in an anterior vector and ever so slightly in a facial vector, so that I can get a driver in
Makes
there.
sense.
If
Yeah.
it's right over the lower cusps of or lower central groove of a second molar, it's impossible to get a
Yeah,
driver.
good luck.
Yeah, I would say too by doing that, a lot of times we're angling our anterior implants forward to get that proper prosthetic right behind the
Divergence.
incisal
Yeah.
edge, so it prevents that
30-degree
divergence.
divergence, yeah.
Yeah. Which luckily now, I mean, I don't know if you guys are doing photogrammetry at all or anything, but something that's been very helpful in my office is our photogrammetry unit specifically will tell you the divergence. So you know that day, like, okay, I need to make a quick adjustment on my multi-unit if
Right.
needed.
Yeah, that's great.
But by having that anterior multi-unit, it matches the anteriors a little bit better as well. And a little tip too for listeners that I've been doing is when I have a case of a patient who, their teeth are flared forward quite a bit, and I'm doing my anterior implants angled forward quite a bit, I will not angle my posterior ones as much, maybe a little bit less than 30, because that will pull those forward as well, specifically when I'm doing pterygoids, so that everything's in line and I get much less divergence on those implants.
Yeah, good.
That's smart.
A question that I have for you about your medial angle for your pterygoid implants is, are you commonly trying to get full bone in contact going through directly the medial plate, or what are your opinions on popping through that process into the fossa there?
Yeah, sure. Okay. Let me just say that this is the greatest thing. The greatest thing about, one of the things I would suggest to anybody is just don't stay alone in your office and stay in your little world. Just social media is great, and this is just to share this passion that we all have. It's wonderful.
Thank you.
I believe that the real anchorage of a pterygoid implant is the pyramidal process of the palatine bone. If you hit a plate, a medial plate, in most cases, you're going to hit it in an area where it's a thin plate. It's really not going to give you much. Maybe it'll give you another cortex, another little bit of stability. But I think most of the stability is really that pyramidal process. So that getting through if you get into the pterygoid fossa between the plates, once you're past that, you're gaining nothing, except maybe causing some trismus for a while, but you're not gaining anything. So extra length, once you do that, is not gaining anything. So I don't see a benefit there. If you can ideally aim towards the medial plate, and if you hit it, then you'll get some more. But most of the real stability is along that path in the palatine bone.
Mm-hmm.
And if you look at an anatomy book and the kind that separates everything out, and look what that palatine bone is, it's a nice, thick, solid bone. You got to be pretty lucky, and this is a blind placement. I mean, unless you're doing it guided, which
Yomi.
another discussion. Yomi,
We're all fans of that.
it's another discussion. But unless you're doing it guided, it is a blind procedure. So you're using the landmarks that you have, and you're gaining the stability as you go. So I'm not necessarily trying to pop through. If I do pop through, I sure hope it's after 18 millimeters. At least I have 18 millimeters of implant before I pop through.
Yeah.
That's my goal.
Yeah, I would say that, I would never know if I was in the, right into the pterygoid fossa, right? So just solid anchorage in the palatine bone versus if we nailed the complete, medial wing there, right? I wouldn't know. There's really no way to actually tell. And and to be honest, if you pop through the medial wing of the pterygoid, you're into the nasal fossa, right? You're in the nasal pharynx, and so I've seen other people's axial slices, and I'm like, that tip of that implant is in air. Like if they ever get intubated or whatever, they're nasally, that that implant may puncture the tube.
This is something too, and I've done this, Clark. Like I've gone. I mean, I'll just I'll put it myself out there. I mean, I'm always going for that medial wing, and just like David was describing earlier with putting his osteotome between the plates, I do the same thing with my lance drill, right? I like to get in between there and actually move the head physically, and I'm always shooting for that medial plate. And I've had a few times where I've maybe there's always this tendency to kind of drift lateral as you drill, and so sometimes I compensate for that, aim a little bit more medial, and like yeah, I mean, I've got a few that start, edging into that nasal cavity. And I've been curious. I mean, they've torqued out wonderfully every time, of course. But I've been curious if there's any negative sequela that could come from that. I'm not entirely sure. I've never taken anything out just because of that.
Yeah, it's way back there. I mean, it really isn't nasal pharynx. So there's good thick mucosa over it. So it shouldn't dehisce through. But like what Clark was saying, I wonder what happens in a nasal intubation or some other trauma or something like that.
Right.
But I mean, generally, how far are you going to poke through? I mean, I would probably say
It's
it's the
never
same
been
thing
far.
as poking through a millimeter or two into the nasal floor is also of no consequence. So.
Yeah. Yeah. I mean, generally, if I'm deeper than, I don't know, if I'm going to play something longer than 22 millimeters, I need to really know where I'm at and have a good idea why. Most of mine are just 18. So, I mean, they're not going to go that far.
Yeah.
But something I was curious about too is, you mentioned how your anterior posterior entry point with relation to the hamler notch is dependent on how much bone you have back there, right? So I'm curious. I mean, I have some cases where there's really not any runway at all. I mean, I got a shell of bone all the way back. Does that? I mean, I've done some of these cases where essentially what I'm doing is a sinus pterygoid implant.
Right.
I mean, I'm curious of your thoughts on that. If there's a way to circumvent that, if it's a non-issue, how do you view it?
So the way to circumvent it, I'm not recommending it, but the way to circumvent it is the less bone you have under the sinus, the more vertical that implant becomes, more posterior. But then it becomes prosthetically useless.
Yes.
So you have to play the game. On the other hand, how many cases do we see that your reduction plane is already in the sinus, whether you have to lift or crush the sinus floor, whatever you got to do, even at the posterior maxilla, at the tuberosity. So if you're already at sinus, okay, ideally you've lifted the membrane there, and you can actually see the posterior wall at that point, which is not a bad thing. You can see the posterior wall, you can see where your medial plate is, and you're already in pyramidal process.
Yeah.
So that's great if you can do it, but it leaves a good bit of implant hanging in midair, not in the sinus, but in midair. What that does long term, do we know? It's not like a zygoma. You have a lot less of less stability. It's less of a bony
Less of a
anchorage.
bending motion or a
Right.
moment.
There's less of a long arm there. That's true. And it is the posterior. It eliminates your cantilever, so there is a benefit. I started this business as a all-on-4 purist. Clark, you probably did too. Malo, you come out of there and saying any more than 4 is an emotional implant. That 5th implant is that it makes you feel better but doesn't do anything. Well, we know that it does do something. I mean, at least the pterygoids, eliminating the cantilever does have a benefit. But I came to it a little later. I used it as an emergency for years. And eventually it's not necessarily every case, but it's most of my cases.
Yeah. I think of it less emergency, more insurance.
Yeah.
Yeah. No, I think go into surgery that you're only going to do it once and do it the best you can. I don't understand other clinicians who say, well, we want to save bone, we want to save this for when we have to redo it. Like if that's your thinking, then why even do it? Because when you have to redo it, it's on you, and it's even harder, you know. So you know, in my practice, everybody gets a pterygoid. We are doing no cantilevers, and I actually compiled my data for Vichy, and I've got over the past 5 years, I've got 964 pterygoid implants completed with only 4 failed.
Wow, that's great.
So it's interesting, you
That's
know.
great. It really is.
Getting all that data, but yeah, when you go to Nobel, they told you that the 5th implant, like you said, emotional implant, or it's the boat payment, right? And you know, I've got a lot of cases where, yeah, they're doing great at, you know, 10 years on 4, but man, if we could have eliminated some cantilevers or given patients extra teeth, you know,
Right.
one thing that I learned a long time ago is when you are treating Indian patients, or you know, patients from, you know, the East, what do they often have that many of Caucasian Americans don't? They often have third molars.
Oh,
And so when you give them a all on 4 on 12 teeth, you know, they are upset. They're like, where's my back
Cheating.
molars? Oh,
that's
we
interesting.
gave you a molar. And they're like, where's the other 4? So
That's great.
you know,
That's great.
just you always have to think of that. That was a big aha, you know, moment of my, you know, Americanism. So just
I've
think
seen the
that
same
through,
thing.
and that's you know, you want to make sure that you're doing pterygoids on them.
I have one.
But
I have one patient right now that uh, I did. You know, I try to do retroframinal on every one of my cases as well to get those back molars, and it was an Indian patient, and I didn't get torque on that, so I just put a cover screw. I usually come back at 3 months, especially in the posterior mandible. Sometimes I'll get those where, you know, I come back at 3 months, expose it, and then add it to my case at that point. And her biggest complaint over and over and over again was that right side was that she was missing 2 molars back there, and for the 3 months that was the worst thing that I ever did to her. Uh, Luckily, it went back in, and you know, it torqued fine, everything looked good, but exact same thing that you were talking about.
yeah, it's just, you know, the learning curve
Yeah.
of full arch. David, I wanted to ask you, you know, oftentimes, you know, when we're talking about pterygoids, and when you talk about PATSI protocol, all right, posterior, anterior, um, you know, middle. I kind of like PAM, right? That's what Juan's been saying lately. If he could rename it, he would rename it as PAM, posterior, anterior, and middle. Um, I don't like doing my pterygoids first. Now, if I know off the bat, hey, this is going to be a bilateral zygoma case, then sure, I will roll in and do the pterygoid first. But just on my run of the mill standard arch, let's say it's, you know, relatively easy in complexity, I actually like doing the anterior 4 implants first before I do the pterygoid, so that I can make sure that I get the platform all on the same level, right? Whenever we're talking about implant depth, I prefer to have my anterior uh, 4 abutments on before I place the pterygoid. I find that really helps me get the correct depth versus having to go back in and forth and take an abutment off because you didn't get your pterygoid deep enough. That's kind of one of the things I typically find
Yeah, it's
in
interesting.
the learning curve is
Yeah.
not placing your pterygoid deep enough. And then when you have your abutment on, it's too shallow, and so you kind of get like a, you know, your prosthesis kind of dips down where that pterygoid is because you didn't get it prosthetically in the right spot.
So yeah, it makes sense. That does make sense. So AMP instead of PAM, but okay, I
That's
get it.
that's how I approach some of my
Yeah.
cases right now. The hard ones, you know, we're doing the posterior, we're doing the pterygoid first, or I actually may do the anterior first on a really hard case. I'll do the 2 anterior ones, just to kind of get a good rep, and then I'll do the pterygoid, and then finish up with my zygoma.
And the logic of the pterygoid first is to help you position your tilted or zygoma, to have that posterior implant. For example, if you don't get the pterygoid, then your zygomatic implant needs to be a little further posterior just to limit the cantilever. I mean, I understand that logic, but assuming that you're going to get them all, your logic is
Sure,
good.
Um,
Your logic is good.
I'm curious too, David. So when it comes to, so let's say you're in that situation where you haven't been able to get the pterygoid. The patient, if you don't get it, the patient probably just doesn't have pterygoids. They're just an anomaly. But let's say you don't have that, and now you're trying to establish that posterior stop, and you're going to do that with a zygomatic implant. Are you incorporating the Hessian zygo, that sort of infratemporal zygo that goes all the way back to the first molar? Are you trying to do that, or is it more just like a traditional A-frame coming out in the first, second premolar?
Yeah.
How are you going about it?
I generally go to an A-frame and go back as far back as I can. Hessian, I've done them. It's interesting. I've done it in a case. I remember the first time I did was a revision case, failed zygomas from elsewhere. And the only zygoma I could get was back there. But I started with the pterygoid first, so that the zygoma and the pterygoid was so close, they ended up burying the pterygoid, not even using it at the end of the day. So it really was a way posterior zygoma. So
Yeah,
there's
okay.
a lot of leeway up there. There really is a lot of freedom once you can get back behind the infratemporal fossa like that. I think it's very useful. But generally, I'm able to, with an A-frame, limit the cantilever the same way.
Are you
Tyler, I would say on your characterization there, Hessian would be more in the pterygoid spot, and
Okay.
a A-frame would be more in the first or even second molar spot.
Yeah.
The traditional Brazilian technique is where they're a little more parallel.
They're parallel. Okay, that makes
and
sense.
that's more in the premolar position.
Right.
I appreciate that. Yeah, that makes sense.
And that's by the way, that's a great use for a zygomatic handpiece if you're doing parallel or an anterior zygoma. I love that handpiece.
Yeah, no,
I love that handpiece, but I love it more for pterygoids now.
Yeah, that makes
Are
sense.
you in a situation where you aren't getting a pterygoid, but you do get the standard 4 in the front? At what point would you consider putting a zygomatic implant in because your tilted implants are too far forward? If you're coming out, canine, are you putting a zygomatic implant back there? If you come out first like what is your logic?
The biggest cantilever I want is going to be a 10 millimeter cantilever. So if I can get to second premolar, first molar junction, I'm happy. Ideally, I want to be at the first molar exit point. That's my ideal, especially if I don't have a pterygoid. If not, if I'm at first premolar or something like that, I'll put a zygo in to get back there.
Got it. Okay.
Yeah.
And then the second question I had was more for people who are venturing into the pterygoid space. If let's say you get a really bad bleed back there, I would love to hear how you manage that. Just some tips for doctors if they run into that situation. What are the steps that you'd take?
So the really bad bleed, you should never get it back into, meaning the pterygoid plexus or the internal maxillary. If you're there, you really shouldn't have been there to begin with. Mm-hmm. So you're going the wrong way. So you really have to follow your anatomy, follow your landmarks. And assuming that you're following your landmarks, I mean, it's like saying, what if you poke in the eyeball? I mean, you just shouldn't have been there. I mean, there are ways to deal with it, of course, but you got to pack the hell out of it. You should have some tools available to help you. Avitine is something that should be in your office, microfibrillar collagen to help the first stage of clots. And by the way, the best way to use that Avitine is if you take a TB syringe, a 1 cc syringe. I do the same thing with bone. You just take a 1 cc syringe and cut off the tip, the Lorlock tip or the catheter tip. Cut that off, and you could use it as a bone syringe too. You take your bone in your dapping dish and just fill it up from the bottom like we used to do with impression material. Just fill it up that way, and then you can use it. You can do the same thing with Avitine. Make little Avitine balls, put it in the syringe, and that way you can direct it once you take your pack. As you take your pack away, direct that syringe into where it's bleeding and start packing that. So packing obviously is the way to do it. In case of the realistic bleed, which is one that you're going too far medial and you get descending palatine artery, there are two things you can do. First, you can try, it depends on where you hit it, you can try and get the palate, compress the palate on the palatal side of the incision, try and get it if you got that low. If it's high, then you have to get into that foramen. Today, I told you I just helped a guy out with a zygo case, and the patient was complaining of some pain. Flap was open and he was trying to get a V2 block, and sometimes you can hit it and sometimes you can't. I said, well, hey, let's cheat. Just dissect that palate a little bit and you can see where the periosteum starts to get into the greater palatine foramen. And just once you know where that is, now you can cheat, put the flap back and you go through there. So I'm saying do the same thing, get into the foramen and use some epi there. And then the next thing is to get into the osteotomy that you've created that caused the bleeding and pack it there. Pack it with Avitine, pack it with gauze, and then get an implant in there. I mean, those are the only ways. Bovie is not particularly beneficial at that depth. You're not going to get there. It's great, by the way. Bovie is a great tool to have. I think some electric cautery is important. It's most important when you start punching the mucosa around your palatal multi-units and you get these little arteriolar bleeds, kind that you can stop for a moment with epi, but then it starts bleeding again when the patient goes home. So use a Bovie when you see those. Or the posterior superior alveolar artery intraosseous branch that you see it across the lateral maxillary wall before you get into it with a zygoma burr or a sinus lift. Just zap it, touch the bone, and it'll burn that too. But the DPA bleeds are not amenable to Bovies. And then the last thing is don't just let a patient bleed out and die. There is interventional radiology for these things. So pack it if you're really in trouble before you get to that level. There is, pack it, stabilize the patient, get into a hospital that has IR, and that can be fixed. But again, the real trouble one is internal max, and you just shouldn't be there. There's no reason to be there.
I mean, on the internal max, you're not going to have time to go to the hospital.
Interesting. It depends. I mean, if you really get it, that's true. If you really get it, that's true. But I've seen some bad bleeds. I have seen a human being bleed out from a face, by the way. I was finishing surgery in the operating room. This was in Memphis. And the chief of surgery comes running up. Zelig, we need you in the ER. And I'm like, you never need me like that. But no. His guy got brought in in a helicopter, ejected from a car. They intubated him in the field. He essentially had a split face. And I packed everything that you could possibly pack. It turns out there were internal carotid bleeds, ethmoidals. And he literally just, unfortunately, watched the guy bleed out. It was just terrible. So, the argument you can't bleed out from your face is just not true.
Yeah. Wow.
It was bad.
Well, let's get off this topic. And I have a Zygo question for you. What do you think about Zaga, and or do you do everything extramaxillary?
That's a great question. So let's just take a Zaga 0 or a 1 where you have a straight wall. Because everything else is pretty much going to be extramaxillary.
Sure.
So the only one that could be intra-alveolus anyway is going to be a Zaga 0 or a 1. Right. And on those cases, the big question to me is, what am I gaining from saving that little millimeter or two? I mean, I'm not going to debate Carlos Aparicio on this, but in my own mind, what am I really gaining? The only thing I gain from that is preventing some dehiscence of soft tissue over the shaft of the implant at the crest. To me, to me, because I'm not using a threaded implant, so I'm not going to get osseointegration in that crest. So that's the only thing I'm saving. It makes it technically more likely to me to perforate the sinus membrane low. I'm talking at the crest. So although I've done it in these cases, you got this really beautiful thick alveolus, and it'd be a crime to grind through it. I've done that, but at the same time, I've made a long enough window in the side of the membrane to be able to lift everything. Not that I'm an impatient surgeon, because I think I got patience to do it right if it takes it, but I question the benefit. I question the benefit. So yes, I've done it in some cases. I don't see a lot of those full alveolus cases, so almost all of them are ground down. Use that lateral extra sinus burr.
So let's just say it's a Zaga 3. You know, you have two options, right? You can either tunnel or channel.
Right.
So,
I channel.
okay, there you go. All right. Well,
I channel. What do you do?
you know, I'm more flexible. I'm a little more open-minded. I tend to be more Zaga versus extramaxillary.
Yeah.
So, but I mean, you're a big Norris guy, right? So Norris likes to.
Well, I mean, that's true too. Today was a neodent case, but I don't know. I wonder. I think that the soft tissue management, I just don't see a lot of the dehiscence. If I'm gonna see it, you know, I can generally predict it, a smoker or something like that, and I use thick tissue. And by the way, I started on edentulous cases. I really went back to a vestibular incision,
Okay.
like a Lefort incision,
Uh-huh.
and bring all that, you know, really punch the tissue so that my incision is far from the crest.
So you're going what, 10 millimeters beyond, or 10 millimeters
into
apical to
free
the
mucosa, into
yeah.
mucosa, and bring the whole thing over. It makes, I mean, in a conventional case, not necessarily Zygoma cases, but in conventional cases, it just ends up looking like, wow, this is healed already. You know, as soon as you finish a case, it's just it just makes it so clean. And then you don't worry about your incision line. The only thing I worry about in doing it that way with Zygomas is there going to be dehiscence along the shaft.
Right.
And if I'm using fat, I'm thick and covered. So I really have not seen that.
So
Now,
just
do you pull fat on every Zygoma case, or will you do like
Yeah.
a scarf graft like
I do both. I do both. Not on every case, but I will do both. Non-smokers with good thick tissue, I don't always do. And if it's a Zaga 1 or so, then I don't necessarily.
Yeah.
So-
I tend to hold the fat, to reserve the fat, and harvest as much pedicalized CT when possible.
Makes sense.
So I'm curious about this vestibular approach, because that's not something I'm super familiar with. So is that to say that you're incising into the actual vestibulum and then
Not quite. It's called the vestibular incision, but it's not. It's essentially it's what's used for a Lefort osteotomy. You're leaving all the attached gingiva attached, in this case, to the palate. And, you know, again, normally you do this in a Lefort osteotomy. There are teeth that stay there. So the attached gingiva stays there. It's not stripped. In this case, it's an edentulous arch. So into the free gingiva, at the attached gingiva, free gingiva junction almost, or further apical than that, and then strip the entire flap over palatally.
And
Okay,
for
so you go
definitely
past the
have to tie
NGJ
that.
and then you come back over, and now when you close, it's
Then
a healed
I
ridge.
punch through. I essentially am
Yeah.
punching through the crest.
Yeah.
Wow.
One of the drawbacks, though, is that you can't thin the palate. But on an
Correct.
edentulous case,
Correct. It's
you
really just edentulous cases.
yeah. It'd have to be a case where you don't have to do any tuberosity reduction or thinning or anything like
So
that.
good. Nice question. So I do when I do, because how are you going to get your pterygoid in? Same problem. So I do change that incision. I have to show you one day. It's
Okay.
towards the crest and then goes vestibular. At the tuberosity, it's crestal over the tuberosity and then comes over it like second.
Yeah, I think I
over.
can see that. Yeah.
Just looks like a denture almost. It kind of goes up and has a flame.
Yeah. Nice.
Nice.
Wow.
No, that's great.
Wow.
Now, one other question. You brought up in one of the chat groups that we're in about basically bracing your zygoma shaft along the palatal wall.
Yeah.
And one thing that I will often do is, because on a scenario like what you're talking about, where you've got a channel right along that alveolar wall, and like let's say that case would roughly be like a Zaga, maybe 1 or 2, something like that, right? Chu, I think is his name. He's out of Hong Kong. He's got a great article. It's an older article, but he lifts the entire membrane and actually does particulate grafting there. I don't like particulate grafting with zygos, but oftentimes what I'll do is whenever I lift, I'll put in maybe some collar tape or something like that, so that I actually will wind up getting some type of bone formation several years after this is all said and done. So I'll still kind of prefer to rest it along that palatal channel, but I'll lift my membrane and then I'll put in a collar tape so that it stays in place, and hopefully we get some bone formation later.
Alternative. Again, these are cases that you have to do so much bone reduction that you're past the sinus floor, right? That's what we're talking about, those kind of cases. So what I'd like to do is start your reductions till you start to see that membrane and there's still bone over it, and just infracture that floor so that there is bone on that inner aspect of your implant still. But it's too palatal. I mean, it's still palatal to the ideal. But that was the alternative. Speaking of using some kind of membrane, is I toyed with using Volumax, thick Ossix membrane. When Ossix first came out, their big claim to fame was that the membrane itself ossifies, so that the thickness of that membrane, you go back in there sometimes and you see that texture of the membrane still now bone. So Volumax, the argument is you got this thick membrane that will ossify in theory. So I started using that actually on the facial of some zygomas as well. Let's see what happens.
Well, that's easier than a Ramus graft.
Yes, it sure is. So that's an alternative, is to use something like that, a good thick membrane. Certainly it'll help with any oral-antral communication, but it might help with some ossification too.
Well, I think that's a really good thought there, the Ossix Volumax.
I'd like just changing topics a little bit. I'm curious, David, what your thoughts are on the best practices for general dentists doing remote anchorage, just for like protection from board complaints and being compliant and making sure. And I don't know if you've seen it happen or anything, but like a general dentist who perhaps had a board complaint or something for a remote anchorage based implant, is there anything that you've seen dentists do to protect themselves from that, to ensure that, and I'm not talking about cases where they were doing something that they shouldn't have been doing, or like in a location they shouldn't have been, but just to ensure that they're staying up to par with someone like an oral surgeon, oral maxillofacial surgeon, if they came across the board and just said, oh, he's a general dentist, he shouldn't be doing this.
So we have the same issue if you think about it. When I wanted so I trained in a training program where we did our own hips. We took our own hip bone, and most of us do today. I went to Memphis, a very conservative town, and they didn't want to let me do it. So I spoke to the chief of surgery. Chief of surgery was an orthopedist who trained at Jackson Memorial, where Bob Marks was, and they wrote the book on grafting from the hip. And he knew that, and he actually supported me. So bottom line is, I had the training, and I had the support of an orthopedist to suggest that I'm right, and it worked. So in this case, it's the same thing. A general dentist should get the training, and we've just discussed what that is. It's, it's the same thing that medical education, letting go of the hands and slowly taking the training wheels off. It's a learning curve. It clearly is. And probably more of a learning curve for a general dentist that didn't have a surgical residency. So take your time, have the backing of the people that trained you, and go out and do it. I don't think that, you stay in your lane, so to speak, do it what you're trained and well trained to do. And I think you should have some backup, somebody to call. So
Got it. Yeah.
Well,
keep your friends.
David, some of the things that I see is just in record keeping, and
That's a good point.
it's
I
very,
was
very
thinking more technical. Yeah, absolutely.
well, sure, but very simple. Everybody who's going to undergo anesthesia, just get a medical consult, right? It's not a medical clearance; it's just a medical consult. So we get that on everybody, and what you get back from the physicians is their entire medical history, right? Like, I've seen people get dinged because they didn't put an ASA classification, on one of their notes, or something crazy. But if you, a part of your record is the patient's record from the medical doctor, you are more than covered, and I think it's also important that, our medical colleagues, they don't give us clearance, right? We are the ones who are deciding to work on. And it's just having a very nice medical consultation letter that you are just asking, is this patient medically optimized, and do you have any objections, and can
is, you've been doing practicing oral surgery and then getting into the full arch dentistry. I would love to hear kind of your tips as far as what you do for your own personal health to ensure that you can, keep doing these surgeries. Because right now, I'm like leaned over upside down in the patient, and I don't think that that's the best for longevity.
Great.
Our dogs are barking, David.
Okay.
And I would love to hear your tips. I know some guys do it sitting down. Like, I'm just curious.
Well, here's what I started with. First of all, I think that all of us are all front anterior chain in physical therapy terms. We're all anterior deltoids and pecs, and everything's in the front. All right, so our backs are critical. So before I started this, I was a power lifter. First it was martial. I was a nut. I was wrestling team and in college and in powerlifting and all this nonsense. So because of that, by now I have a total shoulder replacement, 2 hips, and a knee replaced. That's aside, but I'm still doing all this. I'm still lifting. I'm still doing the rest of it too.
Good.
So I think that staying fit and stretched and all that stuff is really critical. I really think that's very important, which opens up the other thing of balance in life, because I think I had a better balance in life before I became a full arch guy, but that's another discussion. You start to get down the rabbit hole. I do sit in the last 10 years, probably. I started sitting, and I use a sit stand stool. I use a Sally stool, which is like you're almost standing, so you can feel like a surgeon. And no, I'm seriously, because that was the big thing. Oral surgeons, hey, you don't sit. What are you, a dentist? That kind of thing was ridiculous. But it was the thing. So, and everybody in the operating room stands. So this thing is you're almost standing. Your feet are almost straight, but you're in a stool. Sally's stool, great for men, has a pudendal groove to let your prostate be healthy and keep the boys from being asleep. So anyhow, I do recommend that. I do recommend sitting in a stool. If you're in a horse's saddle, you can't slouch. So you really are maintaining a good posture. So I think that's important. But sitting high so that you're still looking down and able to see what you need to see. Headlight, like I said, I don't use the loops. I used to use it for a lot in surgery, but not in arches. I feel like you got to see the whole
What headlight?
picture. What's that?
What headlight do you like to use?
I have the KLS Martin, the MedLed Chrome,
Okay.
but I've tried them all. I have another one that sits on my glasses. I just recently, I'm not wearing them now, but I just got, somebody bought me a gift certificate, gave me a gift certificate for the Ray-Ban Meta glasses, the AI glasses.
Yeah.
And there's a camera in there. I actually started using it for filming in surgery. It's great.
So
I was gonna
someone
do that.
suggested this to me on Instagram, and I was curious. Yeah.
It is. It's great. There's something you can't use your headlight when you're doing that though. It's too
Okay.
bright. But once you take the headlight off, it's great. It really is very useful. It's not
Really,
long enough.
it's a high quality
The video is high
resolution?
quality. It's a high quality resolution. They're limited. You can do live stream, by the way. You can do live stream with it, but the video length is limited to like 3 minutes. But
That's
you
what I
want to
was
show
gonna ask.
somebody something, you can take pictures and you can do little snippets. It's been
Oh,
great.
that's cool. Yeah.
When you're doing I actually, I was just gonna ask about the 3-minute thing, because when Tyler and I, previous to what we're currently doing, we were doing a lot of a clinical director, like helping people with their first surgeries. So we were taking a lot of video, and it's always a pain in the butt to have this video camera like above, and it's
Right.
like focusing in and out every time you lean forward.
Yeah. What's that? There is a camera that is on the overhead light.
On the boom.
Fujidan, I forget what it's called, but there's one that does well. But the other one, I got that headlight camera.
I have that too.
The
But
$5,000 eye camera?
yeah, it
I
was,
don't like it.
what else am I going to do with the money, But anyway, it's very uncomfortable, and
It's heavy. You're like,
there's a lot, right? There's a lot of this going on, so I haven't found the secret.
so when you're doing when you're on your Sally stool and you're doing it, you're at the 12 o'clock position. Are you doing your mandibles from the 12 o'clock position?
Yeah, more the mandibles. So 12 o'clock to 3 o'clock. I mean, I'm to the side of the patient as well, but I try more I can do from behind, the better. Patient is flat. That's the other thing is, when I'm doing my own sedation, my own deep sedation, the worst position for a patient when they're in open airway is flat. So, but it's the right way for us to do surgery. It's the easiest way for us to see the maxilla and the mandible. So I do fight it. When I'm doing my own sedation, I often use a nasopharyngeal airway to help with that. When I'm elsewhere, not in my own center, I have an anesthesiologist, the patient's intubated. That's beautiful. So I have no airway issues. And when I'm doing the mandible, I'll just sit the patient up a little bit, so I'm looking down. But I try to be, from the standpoint of when I'm doing the osteotomies, I'm behind the patient. It just makes everything symmetrical.
I have tried doing that so many times, and I always come around to the front of the patient to do mine, but it's just one of those things that
you got it. But as long as, if your back is straight, that's the main thing.
Yeah.
You just keep your back straight and look down, keep the patient low, and just looking down at him.
Good. Well, hey, I appreciate those tips. That's great. And
yeah, we need them.
It's something that a lot of people don't think about, but I'm hoping a long career ahead. And
yeah, well, get out there and play pickleball or something.
Yeah. Oh man, but yeah, maybe I'll just start wearing one of the powerlifting suits. With the.
Those are beautiful.
Just the belt, the belt during the surgery.
Yeah, I have done that actually. I pulled a muscle one time. But no, that's great. And so, that question kind of alludes to, how long you've been doing this and your ability to continue to do it. I'm curious about, looking forward for yourself professionally. Obviously, you've been doing arches a long time. You're practicing at the top of what we can really do. What are you looking forward to for the rest of your career? Do you see more advancement, more growth in your clinical pursuits? What do you see for yourself?
It's so funny. Everybody, I have friends that some have retired, some are retiring, some are slowing down, some are everybody else. And I'm like, I'm still on fire on this. I love it. It's great. There's an old singer. That was the other thing I did, was I was in a choir, but anyhow, this guy, we did this opera together, and the old man sang, "In the winter of my life, I feel like it is spring again." is what he's saying. I'm not in the winter in my life or anything, but I feel like this is keeping me going, excited in this every day. I love what we're able to do for patients. It's a privilege. It's a privilege, and I love it. So do I want? Yeah, I definitely want to do more. I want to keep teaching. I want to help the next generation, and just keep doing the right things for patients.
Yeah.
That's it.
Yeah. And looking forward for, yeah, obviously you've had the wisdom and the experience to see how far full arch has come, all the way going back to, when Paula Malot was first talking about this kind of
Yeah.
stuff. So, you have probably as much authority as anybody to say, what does it look like for the next 10 years? Where do you think full arch is going? What do you think people will be talking about on podcasts in, 2035 with regards to full arch?
That's great. I definitely think that we're getting to a point where we got a system that works. The patient-specific implant is going to find a way to get perfected for the multiply revised cases. Having had joint replacements, I think I could also tell you that orthopedists look at these things differently. They don't call failures failures. You need a revision, and you need a revision because a car is not going to last forever unless it's maintained perfectly, and even an antique car is not going to drive the same as a new car, even if it's well maintained. So things do change. It doesn't mean failure as long as it's done right to begin with. Things can wear out, and we have the tools now to go to the next level. What is it going to look like? I think the business model is probably going to change. Some of the new guys with the great new ideas. We talked a little bit about the immediate finals. I don't know that that's going to last. I think that you also talked about the lifetime warranties. I don't think that people can stay in business when they're advertising pie in the sky kind of things that are not necessarily going to work. But it might be the flash in the pan. It might work right now.
Yeah.
I think the guys that are doing it right, responsibly, will end up, if I could use the term winning, will end up just being in for the long game.
You'll still be doing it by then.
Yeah. I don't know about me doing it, but I'm saying, it's as long as you're doing the right thing for the right reasons, you'll still be doing it.
That's great.
Well, we definitely appreciate having guys like you that are helping us and the next generation with these advanced techniques, and making sure that guys like Tyler and I coming up have the ability to fix these cases when we need to. Because without people like you, we wouldn't be able to, or we wouldn't know where we could go, when stuff fails.
You honor me by saying that, but you have no idea you're giving us life. I don't know what to say. It's great. It's great to have that. It's great to have that. Because I had that, I had those mentors.
Yeah. Yeah. I mean, oh, Clark, we lost you, I
Oh,
think.
you're on mute again.
Yeah.
Clark,
I'm
can
sure.
you check your...
I think now it's easier to have a tribe, right? And so it's easier to, collaborate. It's easier to talk about cases. And so I think that, advancement will be quicker, and it will be, better. I don't know what is around the corner. I don't know how it can get any better. I mean, I think what Malo, came out with, really started off a lot. And then what, things, like Dan, coming out and, I was doing pterygoids before Dan's book came out, but, Dan has really kind of helped, talk about pterygoids and then bring in the no cantilevers and really kind of broaden that out to where I really feel that, our implants are better and our patients are being treated better. So it'll be a fun, next chapter. But I think that the clinicians who are coming up, I think they have a better education experience, better access to education, and access to a community.
Yeah, and you can find that at Clark's course. If you need good education, it's a good spot to go for sure.
Yeah, that's right.
Tyler and I and Caleb, who's our other partner, we talk about this a lot. about, because we always are trying to stay ahead of the curve when it comes to like the business side of full arch. And where we're really excited about is the potential for a lot of like the AI and the prosthetics, as far as, I'm sure we'll get to a point where a lot of the design is going to be done via AI, and maybe you can take a picture of a patient, right, and then get a smile design, and that smile design will turn into, a surgical guide, right, or just like the provisional prosthetic already designed for you on those multi-unit positions. And that's what we're really, really excited for. I think that is going to be coming here pretty shortly.
Yeah. Yeah, I think a lot of the advancements we'll see are going to be on the prosthetic side and on the actual planning side of things, right? I mean, we had Dr. Sven Bone on here not too long ago talking about his programs that are doing fine element analysis to look at prostheses and figure out where their weak points
Will
are.
it
And
break?
that's some, yeah, and that's some, will it break? Exactly, precisely. And, that's an AI driven thing. AI can be driven to, either generate or analyze an implant plan, on an extremely atrophic case. It can figure out where the stress points are, or maybe even a patient specific implant, like David was mentioning, finding where those stress points are going to be and how that's going to work out prosthetically. I think it's going to make us a lot smarter in terms of, what we're putting on top of our implants. But my hope is that the Yomi never catches up to us and we'll still be the ones executing these surgeries. That's
There
the
will
thing that
always be a human
yeah,
being
yeah,
operating on a human being.
yeah, that's what I'm hoping for. I hope I get David's age and I'm still talking about, slinging arches, on the daily, and that's what I'm still able to participate in, and this will only get better as we go. But I guess time will tell.
I have a perfect, not that I need a closing line, but we opened, maybe before we started recording, I thanked you for sending me what I called the Rush Limbaugh EIB microphone. So Rush Limbaugh, it turns out, if I can quote him again, before he got sick and before he died, he was also a tech expert, an Apple expert.
Mhm.
He said, "I'm not afraid of dying. I'm afraid of all the tech I'm going to miss."
Mm.
And I think that's, that applies here, man.
Oh, yeah.
We're all growing up and getting older, but look how this is growing. It's
Yeah.
amazing.
It is.
great.
I mean, going from just, and I think David, you might have mentioned that still a lot of your cases are analog, but from analog to, and I know yours are too, Clark, but go ahead.
No. I said I was analog and trying to figure out all this tech that you sent me to set
got it.
up.
Okay.
No,
I read it
I'm
too
mostly
quick.
digital. In
Got
that
it.
world, I'm mostly digital.
Yeah.
Clark
But
is the dinosaur here.
Yeah. Just
Hey,
like the,
well, I don't have a prosthetist that I can just bring in and just say, okay, give
Right.
him the teeth,
Of course.
yeah. But the advancements on the digital side in the last 5 years have been exponential, which is
Amazing.
so cool to be a part of. And, I'm incredibly excited to see what's to come in the next 5 years in that front.
For sure. Well, David, thank you so much for taking this time with us to share your knowledge, your wisdom, and the energy you brought forth with this is it's just amazing. And you're obviously genuinely interested in this and appreciative of what we do, and that's just extremely humbling. Just as a host of the show, to have that. And Clark, of course, thank you so much for sparing your time to come on. And I appreciate the how you've escalated these conversations, because you're certainly able to pull more out of David than we are, given your experience. So I think this has just been an incredible interview, and I really appreciate you both for coming on.
Thank you for the opportunity. I want to learn more from you guys.
Well, you're too kind. Well, maybe we'll have you back on the show in the future, and we
Appreciate
can
it.
share some more war stories. So thank you guys so much, and thank you all for listening. We'll see you next time on the Fix Podcast.
Thank you. Have a
Okay.
great night. Bye.
Thank you.
Bye.
All right.